Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. Welcome to our second online lecture on Dhahran Eye Specialist Hospital. Our lecture today will be given by Dr. Fatima Shamlan, pediatric ophthalmology consultant and the medical director in Dhahran Eye Specialist Hospital. She will give us a talk about the challenges of dealing with amblyopia. Welcome, Dr. Fatima. The microphone is yours.
Thank you, Dr. Sultan, for the kind introduction. Good afternoon, everybody. Today I'm going to be talking about the challenges of dealing with amblyopia, as this is a very hot topic that we face in pediatric ophthalmology and as pediatric ophthalmologists. Let me start with this statement. With 625 million children under the age of 5 years worldwide, more than 15 million may have amblyopia, and more than half of them will not be identified before they reach school age. This is a very important statement that will convey a message that we will explore together during this lecture. Let me start with the first challenge. First challenge is knowing what is amblyopia. Before we can tackle an issue, we should know what this issue exactly. Just for the information, any picture you're going to see in this lecture is a public domain picture, and any graphic design that was conveyed here is I designed it myself, so copyrights are being preserved. Now, when we talk about amblyopia, a lot of the physicians consider amblyopia is only if there is a decrease of vision in one eye and the other eye is 20/20. And this is a bit of a misconception, since amblyopia is defined as the reduction of best corrected visual acuity of one or both eyes that cannot be attributed exclusively to a structural abnormality of the eye. And that means that when a patient or a child comes to the office with a vision of, say, 20/60 and 20/40 in the other eye, we wouldn't consider this patient amblyopic unless you provide him with the best corrected, or you have the best corrected visual acuity. And you cannot say this patient is having his best corrected visual acuity without doing cyclorefraction and giving him the best mode of refraction that would correct his vision. The other thing is amblyopia is not only a unilateral disease. Amblyopia can be unilateral and can be bilateral. The third most important component is you cannot say that this patient is amblyopic unless the patient is not having any pathological structural eye disease. Yet, if you have something that is occluding the visual pathway, such as corneal scars, such as lens cataract or vitreous hemorrhage, then this would be considered a deprivational amblyopia caused by something that is obstructing the visual pathway, yet not a pure structural abnormality of the eye itself. So the first challenge is for us physicians to know what is amblyopia before tackling the issue. The other thing is we have to have a common language when we're talking about amblyopia and staging it. So we have mild, moderate, and severe amblyopia. When you tell me that the patient is having a mild amblyopia, that means that the patient's vision is below 20/20, that is complete vision, and reaching up to 20/40. When the patient is having moderate amblyopia, then his vision is between 20/40 and 20/80. Patient with a vision worse than 20/80, and I mean best corrected visual acuity, then this patient is having severe amblyopia. This is also very important when we come and tackle the mode of treatments and what to do and when. Why do we bother? Why do we treat amblyopia? Amblyopia is a reversible visual loss till a limit, and then it will be irreversible. We have a time period and a time frame. If we don't tackle amblyopia in that time frame, then we would have the irreversible vision loss. Also, amblyopia does not only affect the eye, it affects the whole patient, and we're not physicians that we're treating only an organ. We're treating the whole patient as a whole. So when a patient or a child is having amblyopia, this will affect his school performance, will affect the fine motor skills and social interaction, as well as his self-image. Another important factor, if we don't treat monocular amblyopia and anything happens to the other eye, the patient will have total blindness. So that's and also a very important message to convey. Treating a reversible blind loss will let you have the other eye being protected. So the patient won't go into total blindness if anything happens to the other eye. Now, the second challenge is all aboard. And I mean by this, amblyopia is not only something that the physician can handle. In general, pediatric ophthalmology needs a cooperation of the patient, the parents, and the physician. All parties should be aboard for the train of treatment to go ahead. I put this label of questions and answers to emphasize the time that should be spent in the clinic explaining to the parents what is amblyopia, what are the implications of treatment, why are we treating, what are the future that the child might have, what is the pros and cons of the different modes of treatment, so everybody can cooperate with each other so we can reach to the ultimate goal, which is 20/20 vision in both eyes. One of the most important obstacles that we have in treating amblyopia is parents' awareness. A lot of patients that come to my office, unfortunately, they're not aware of amblyopia. They don't know what we mean by amblyopia, what is lazy eye. Some of them will get shocked at the clinic that their child is not seeing in one eye. This is a silent disease. The child won't complain about having one eye, a vision in one eye lesser than the other. So parent awareness is very important. This is a study that was recently published in Therapeutic Advances in Ophthalmology, August 2019, regarding the awareness of amblyopia among parents in Saudi Arabia. I did not put the whole study due to the time limit that I have, so I just highlighted the most important results that came out of this research. First of all, this research conducted on 1,649 participants through Twitter, a questionnaire that was distributed in Twitter, WhatsApp, and emails. As you can see, the majority of the parents were having a higher education degree of university degree. 15% only had a high school or lower. The remaining were either diploma, master's, or having a PhD. Yet, 70% of those participants did not hear the term of amblyopia and had no clue what amblyopia is. Only 30% of them had a clue of what amblyopia was. Majority of the participants, also 60% of them, never got the eyes of their children examined, never had a comprehensive ophthalmic examination. And that shows you the gravity of the awareness that is happening in our community. And I think part of the issue comes to us not explaining to the parents or having the health education needed for the parents to go forward and understand what amblyopia is. There's also a significant difference found between father and mother regarding the awareness of amblyopia, and this is very important in our social status or environment. Since the mother is the major caregiver in our community, usually I ask the parents, if the father is the one who's bringing the child without the mother being around, I would ask him either to put the mother on speaker. I would explain to both of them what's going on, or I would take the phone from the father and talk to the mother directly. If the mother was not around for any reason, I would request from the father to bring the mother on the next visit so I can explain exactly what's going on. That does not mean that fathers are not keen about their children. Usually, the majority in our society, the mothers are the one who are taking care of the kids. So the optimum or the best situation is to have both parents in the clinic with me. Also, which is something might be a correlation, not a causative factor, yet it should be considered when you're in the clinic, the marital status. They found that parents who were married would be more aware of the disease than those who were divorced or widowed. And also this emphasizes a very important part in our practice as pediatric ophthalmologists. We're not dealing only with the child, we're dealing also with the parents. We have to take into consideration when planning the treatment, the social economic status of the parents, the educational level of the parents, and how can we tailor the information that we would give them. Spending time with the parents is very, very important step in treating amblyopia. I had once a colleague that said I wouldn't bother explaining the treatment, the prognosis to those who have low socioeconomic status or lower educational level because they wouldn't understand. And I think this is a grave mistake. Equality of educating parents or patients should be the component of the work of a physician. You cannot guarantee that the treatment will be delivered to the optimum level if you don't explain enough. You should tailor your explanation, the way that you provide the information according to the status of the patient or the parents in our situation. One of the expected results were found that parents who had a child with amblyopia were more aware of the disease than those who had none, and this is expected. Now, the other part of our challenge is parents' compliance. Sometimes the parents are aware, they know that they should patch, they should give the treatment, yet they fail to comply because they think that if they patch, they put the glasses, that the vision should have improved on the next visit. So you should emphasize on that part, that the treatment might take a long time, yet you will see the result if you continue. Persistence is a very important part of treating amblyopia. The other thing, I always tell the parents when they come to me that I'm the chief in command, yet you are the soldiers that are facing the battle. I cannot do anything if you don't comply to the mode of treatment that I'm giving. Usually this would have an effect on the parents. If it fails, I will let them know that their follow-ups, that they're coming to the clinic, bothering to come and taking their time and wasting it won't be beneficial if they don't comply with the treatment. Sometimes I give them the example that if your child is having a fever of 40 degrees Celsius and I give you the medication for you to give it to the child, you do everything in your means to give it to the child. Yet this is the same thing with amblyopia. If you don't give the mode of treatment that we're prescribing or advising, then the child won't improve in vision. I would go and stress on, if you don't treat the child till a specific age, then if anything happens to the fellow eye, the child might be blind. The other issue is a lot of parents are concerned about glasses. They might even get depressed if you tell them that their child needs glasses. And here it is very important to reassure the parents. Tell them glasses. Some of them think that the black colors around the eye is due to the glasses. If the child has discharges because of the glasses, you have to educate them, reassure them that glasses won't cause any harm to the child. Majority of our population are wearing glasses. Now there are fashionable glasses, and with time the child might have the power decreased, or maybe we wouldn't need the glasses with time. So just reassurance is very important, also part of explaining what's going on with amblyopia. The other thing is the child compliance. The parents are compliant, willing to do whatever you need them to do, but the child is not compliant. And in this situation, I would ask the parents to take the child with them to the optical shop if refraction is needed. and to choose the frame that he wants, the color that he wants. This is part of letting the child get engaged in the treatment. The other thing is children like compliments. So I would ask them to put a board, put stickers. If the child reaches 7 stars for every day that he's complying to the treatment, we would give him a small gift. When we're doing patching, I would ask them if the child is patching during the time that he's supposed to patch, then try to give them the iPad, iPhone during this period. Let them do like a conditional psychology. The time when they're not on patching, they will not get anything. The time they're on patching, they will get whatever they want. And this sometimes happens. Again, there are those children who are even resistant to compliments. And in this case, I would use the good cop, bad cop situation. I will tell the parents in front of the child that I have put surveillance camera in their home and I'm watching the child. And they have my phone, they can call me when the child is not patching. And this works, believe it or not. Once the child complies after being resistant, I would compliment him in the clinic. I would give stickers, I would give small toys. I don't advise giving sugar or candies because of the sugar rush and it's not healthy. And I would give hug, I would hug the kids and I will tell them that they're the best patient that ever came to my clinic. And this works very well with children who were previously resistant to treatment. Third challenge is age just a number? Well, the answer to this is yes and no. Age is just a number in some situations, and in some situations, it has an effect. Treatment of amblyopia can be effective beyond the age of 7, yet the treatment may be slower, the effective response to treatment may be slower, and it would require a higher doses of patching. The patient may not reach 20/20. Yet you have to give those patients the benefit of the doubt. Even children who are beyond the age of 12, if they did not have any previous treatment of amblyopia, you would start them on the mode of treatment. Usually patching, the maximum time of patching, 6 hours per day, is effective in some of those children. And thus age is just a number in those children who did not have a previous treatment of amblyopia. And those children who were you were following them up, you're seeing them, you gave them the maximum treatment, and yet they reached the age of say 9 to 12 and there is no improvement, then in this case age is a part of the challenges that you're facing, and you would tell the parents that this is the maximum benefit that your child might get. Our fourth challenge is what to choose and when. Which mode of treatment would you go for a child with amblyopia? And this depends on different factors, the severity of amblyopia and the type of amblyopia. If we're talking about deprivation in amblyopia, you would go with removing the causative factor, which is either cataract, the corneal scar, or vitreous hemorrhage if it is there. And then you would go with the visual rehabilitation, the usual classic treatment that we go with. Let's start first with the optical correction. To give or not to give, that is the question. When you have a child with refractive error, when shall you give the glasses? When shall you not give? Because some of the refractive errors are not amblyogenic. They're expected to be there at a specific age, and some of these are amblyogenic. There are different studies recommending different prescriptions according to the different diopters that you find in psychometric refraction. For example, here are different statements like isoametropic amblyopia occurs usually in children with hyperopia greater than 4.5 diopters. Myopic anisometropia rarely causes amblyopia until anisometropia is more than 2 diopters. That means that the difference between both eyes who are myopic is 2 diopters. Hyperopic anisometropia may occur with as little as 1 diopter difference. Anisometropia of astigmatism or anisometropia by itself can reach up to 1.5. If there is anisometropia, then this is a causative of amblyopia. In treatment of anisometropia, we conducted a study here in Dhahran Eye Specialist Hospital. I conducted it with the fellow. She was at that time my fellow, Hassa Al-Ammari. Now she's a consultant in Bahrain. I'm very proud of her. This study was dealing with the different types of anisometropia. There are limited studies concerning which type of anisometropia will have the more benefit of treatment. And we found that hyperopic anisometropia, those children with hyperopic anisometropia will benefit the maximum of the treatment. Yet when they present to the clinic, they'll be the ones with the worst vision. So they're very highly responsive to treatment. If anyone wants the study, I can deliver it to them later on. Now, this is a table which is, I find it very helpful, giving till which limit you would not give the glasses and when will you give the glasses in cases of isometropia and in the cases of anisometropia, according to the American Academy of Ophthalmology and the Pediatric Eye Disease Investigation. Usually the American Academy recommends that you would give in patients with myopia glasses if the child is more than -4 or equal to -4, and minus if he's equal or more than -3 in children who are older of age of 2 to 3. In hyperopia, if the child is more than 6, and they recommend that you would decrease it by 2 diopters for reaching +4. In the classic teaching, and when we do any patient with esotropia, we would give the full correction. Why do they recommend reduction of the glasses on those kids who are hyperop? Because kids who are hyperop usually do not tolerate the full correction. So what we start with decreasing it by reducing it by 2 diopters and then increasing it accordingly with the follow-ups that we have for that patient and seeing the improvement of vision later on. Usually I go with the pediatric ophthalmology, the pediatric eye disease investigation group, which is because it's easier and more conservative. Usually patients who are myope more or equal to -3 or +3, in case of hyperopia, I would give the glasses. And those patients for anisometrop of approximately 1.5, I would prescribe glasses for them. Now, could refraction alone be a treatment of amblyopia? Yes. Usually when patients come to the clinic, I would give the children the full correction, or in cases of if it is equal, I would reduce it by -2. And then I would follow those patients after 3 months and see if there is any improvement of vision. If the vision is stable, then I might go with additional mode of treatment, such as patching, penalization, filters. I would ask the patients at that time also to use near objects such as iPhone, iPads, drawing, coloring to improve the vision. In this study that was conducted by Carter et al. On 2006, it was found that 1/3 of amblyopic patients treated with optical correction alone had a complete resolution of the amblyopia and reached 2020. Now, regarding the filters as initial treatment, is it beneficial or no? Usually we give the filters as adjuvant treatment when we're doing penalization or patching. This study was conducted by the Pediatric Eye Disease Investigation Group on 2009 as for filters being an initial treatment for moderate amblyopia. As we said, those patients between 20/40 and 20/80. I will not go into the details, but what they found is that those patients who were put on filters, where the treatment was not inferior, neither inferior nor superior to patching. So it was equivocal. Yet the correspondence or the compliance of the parents was higher. But again, patching was still the gold standard. In this study, the majority of patients were anisometrope, and with patching, the patient improved by 2 lines or better. So, as you can see, still patching is the gold standard. Now, regarding video games, a lot of things has came up. A part of it is video games, special glasses that the patient could wear, and with different filters and contrasts, so the patient can use both eyes. We wouldn't patch the other eye. But the disadvantage that the child can take off the glasses anytime that the child wants. It's not like the patch where it's stable and stuck to the eye. The other thing with video games, usually we give the child glasses where the contrast is more in one eye than the other, and the game is more clearer in one eye, the amblyopia eye, than the fellow eye. And it depends on the dichoptic training, where it depends on stimulating both eyes, the visual cortex of both eyes at the same time. Again, a lot of limited studies have been raised regarding video games, not like patching, penalization, because these are the classic modes of treatment, and they were there since a longer time. Yet, still video game study are showing that it's not superior to patching and penalization. Those kids, usually in my clinic, what I ask for them, I don't do the dichoptic training. What I ask is for them to patch one eye and try to do the video games with the amblyopic eye. If the child did not like it, I would not stress on it. I will tell them, let them watch whatever they want or use whatever near interaction they want to go with. Regarding patching, still patching is as I said, is the gold standard. It's still the mode that brings the amblyopia to its knees, if the compliance was there. There are different type of pads that we can use to attract kids with. For example, here for boys, blue color with different shapes, girls with pinky, butterflies, and there are the pads come with near exercises, so they can draw, they can play during that time. And for boys who like Pirates of the Caribbean or whatever, they can wear the fabric pad. This is different studies that came regarding the patching. After stable visual acuity was achieved with spectacle, for those children between 3 and 7 years old, amblyopic children were randomized to patching and improved 2.2 lines. Moderate amblyopia, 2 hours of patching was similar to that of 6 hours, and in severe amblyopia, 6 hours was similar to 12 hours of patching. And usually in my clinic, I divide the patients to mild, moderate, severe. Those who are mild, I would give them 2 hours of patching. Those who are moderate, I would give them 4 hours of patching, and those who are severe, I would give them 6 hours of patching. What about the comparison between patching and penalization? Atropine, Dr. Sultan, if you're around, just tell me if I'm taking a lot of time in my lecture, because I think I'm in the middle of it. Atropine and patching result in similar improvement in visual acuity as an initial treatment in moderate amblyopia, and it was superior on those patients which improved more than three lines after 6 months. Children with severe amblyopia, atropine was was given to them and showed an improvement of 4.5 lines. So patching and penalization are equal to each other. Yet, usually what we do in these kids, we start with patching. If the compliance is not achieved for any reason, we would shift to penalization. In penalization, using atropine 1% ointment, I would ask the parents to put it 3 days a week. That is on Sunday, Tuesday, and Thursday. And I ask the parents to lay the child off on the weekend. Atropine is being used every other day because of the long acting of the atropine. So if you put it on one day, it will work for the whole 2 days later on. Now, in comparison between atropine and patching, it's only atropine is being used only once. Patching can be used for 2 hours, 4 hours, and 6 hours, and some children cannot tolerate the full amount of patching, which is 6 hours. And in this situation, I would ask the parents to divide the doses. Would give 2 hours in one time, then break the patching, give them 2 hours in a later time, for example, morning, afternoon, and then at night. For the maximum time to be 6 hours, if I want the dose 6 hours. If it is 4 hours, I would break it into 2 and 2. Now, patching, the irreversibility is immediate, yet with atropine, it would take time. Binocularity is not achieved with patching. A peripheral binocularity is achieved with atropine. Compliance always poorer on those patients with patching because it needs the consistency. Yet with atropine, putting the ointment only at night would not have that issue of compliance, lack of compliance. Complication is more serious with atropine, and as we said, the child won't resist the ointment as he would resist something being stuck into his eye. Both of them have equal results. Let's go to the other mode of treatment, refractive surgery in children. And this is a big debate between pediatrics and refractive surgery. Regarding pediatric surgery, refractive surgery in children, refractive surgery would be recommended by a pediatric ophthalmologist if there is a high anisometropia and the child is having different glasses being used on both eyes. I mean, one is, for example, -12, the other one is emetrol. In this situation, children can tolerate anisometropia. But if the child cannot tolerate the difference between glasses, this would affect the psychological status of the child when he's having different glasses of different measures, and being in school, the child may be teased, bullied. In this situation, refractive surgery might be indicated in the form of intraocular contact lens, in the form of a laser, in the form of clear lens extraction. Usually, refractive surgery is being done on children who are around the age of 10. So if we're doing it in a child who's already amblyopic, then there is no benefit of doing the refractive surgery. I think refractive surgery should be done on those children who showed an improvement in treatment of amblyopia, and you need to continue the treatment, yet you need to decrease the level of anisometropia that you're having. For example, patient is -3 in one eye and -10 in the other eye. I would recommend having a refractive surgery that will take the patient down to -3 to equalize the measure between both eyes, and then go ahead with the treatment. The other question is, which I face a lot by my fellows and residents, is who came first? I call it who came first, the chicken or the egg? When they ask me, what shall we go for first, strabismus surgery or the treatment of amblyopia? And in this, we need to know the underlying cause. If the patient is having a deviation, and this deviation, the strabismus, the deviation and the alignment is due only strabismus, then I would go for the alignment. I would correct it surgically, and then go with the amblyopia treatment, because the cause of the amblyopia was the deviation in the eye where the image was suppressed by the deviated eye and the patient is only seeing with the good eye. If the patient is having combined anisometropia and strabismus, then I would start with the amblyopia treatment in the form of patching, refraction, penalization, and follow the patient up. If there is an improvement of the vision, some of these kids will have improvement even in the alignment. Once there is stabilization in the degree of the deviation and the vision, I would go for the strabismus surgery. Fifth challenge, I call it, when will I see you again? Follow-up. When shall we follow up those patients? We should follow those patients up. This is according recommendation from the International Council of Ophthalmology. To make it simple, I use the high percentage and the low percentage occlusion. I wouldn't consider high percentage and low percentage occlusion. I would consider all my patients as a high percentage occlusion. I have the time to follow those patients closely. If I have the chance to follow them closely, I would follow them closely. There's no harm of the patient coming to my office earlier than the harm of them coming late and having decreased vision. So I for every year age, I will let the patient come to me per month. I mean, if the patient is 1 year old, I would ask the patient to come to me after 1 month. If the patient is 2, after 2 months. If the patient is 3, after 3 months, etc. Maximum that I do is 3 months. Even if the patient is 5, 6, 9, I would ask the patient to come after 3 months. That is if I'm on the treatment side. If I'm on the maintenance side or observation side, I'll ask the patient to come every 3 to 6 months, with repeating the cycle refraction every 6 months and examining the patient fully. Now the patient came to our clinic. We have different scenarios. After we did the awareness, we are sure of the compliance, or maybe we're not sure of the compliance, but we stressed on the compliance and we started the treatment. One of them is, what if the both eyes had the same vision? I mean, the vision did not change in both eyes. In this situation, I would consider that this patient is having a lower dose than what he's supposed to have, and then I would increase the dose of the treatment that I'm giving, either by increasing the glasses or by increasing the hours of patching. The other thing, if the visual acuity in the amblyopic eye is improved and the fellow eye did not change, in this situation, I would go for I would consider my treatment as successful, and I would follow the patient up with the same regime. What about if the visual acuity in the amblyoptic eye has decreased and the fellow eye is stable? If there is a vision that has decreased than what's supposed to have in the amblyoptic eye and from the first visit, then I would re-examine the patient up. Maybe something came up with the eye. There is an organic lesion or a disease that is there that was not there before. So complete ophthalmic examination should be done, and full psychoplegic refraction and comprehensive ophthalmic examination should be performed in the clinic, and re-evaluate the patient again. The other thing, compliance, you should check compliance, either from the child or the parents. What if the visual acuity in the fellow eye decreased? Then the parents were doing exactly what you were telling them, and maybe they were more enthusiastic and have increased the dose that you asked them to have. And in this situation, I would seize the treatment that I gave and ask them to come to me at a different time, a closer follow-up, and recheck the vision in the fellow eye. This is a very good sign. It's a good sign and a bad sign. The bad sign is, the bad news is that the patient is having decreased vision in the good eye. The good news is that means that the patient's eyes are very responsive, or the brain is very responsive to the treatment that you're giving. That means that your treatment is doing excellent with the amblyoptic eye. So what you do in this case, you would taper patching. After you cease the patching and the vision comes back to the first visit that the patient came to you, then you would consider having the patching being tapered, decreasing it with time, spacing it. For example, if the patient is on 4 hours per day patching, I would go from 4 hours per day on the first month, 2 hours per day on the second month, and then every other day of 2 hours per day, and cease the patching for the third month. And I will ask the patient to come back to me and examine the vision. If the vision drops after this in the amblyoptic eye, then I would go for, I would taper it even, I will space out the tapering. So I will start with, for example, 4 hours for 2 months, 2 hours for 2 months, every other day for 2 months, and then I would ask him to cease the patching for 1 month and come back to me again. Now, this is a good diagram that will finalize whatever we said regarding the mode of treatment. First of all, you have to, in case of anisometropic or strabismic, you will treat the refractive error. If there is any improvement, you will continue with the treatment. If there is no improvement, you will either go for patching or you will go for penalization. Usually, I go for patching. And if there is no improvement in patching, I would shift to penalization. And if the patient, the penalization works, I would continue with it. And if it does not work, then I have to reevaluate the patient again and see what's going wrong with the patient. I'd conclude my lecture or my talk with this statement by Nelson Mandela that says, history will judge us by the difference we make in the everyday lives of children. And I think this is a very important message for us as pediatric ophthalmologists. We make history of these children by changing their lives. And there's nothing that could change the life of a child like having him switch from a vision that is not optimum to a 20/20 vision. You cannot see the future with vision less than 20/20. Thank you very much. If you have any questions, you can.
Thank you, Dr. Fatma. Was excellent talk.